On behalf of Hospice of the Piedmont, welcome to the E-Series, an educational webinar aimed at engaging our community, exploring relevant topics, and educating about ways to connect with our organization. Funding for the E-Series is provided by the Dr. John A. Lusk Fund for Hospice and Palliative Care Education. My name is Ryan Biagini, and I am your host. Today's episode concludes our current series, Exploring Our Community, Navigating Health Disparities at End of Life, a conversation between CEO of Hospice of Piedmont, Trent Cockerham, and Homa Magsi, the new Vice President of Medical Affairs and Chief Medical Officer at Hospice of the Piedmont. Trent joined Hospice of the Piedmont in 2013 as the organization's third CEO since its founding in 1981. He has 25 years in healthcare leadership. Most recently, he led the organization in navigating a successful merger with Hospice of Randolph. Thanks for being with us again today, Trent.
Good to see you, Ryan. Great to be here. Thank you.
Dr. Homa Magsi joined Hospice of the Piedmont in October 2020 as the Vice President of Medical Affairs and Chief Medical Officer. Board certified in both family medicine and hospice and palliative medicine, she is also fellowship trained in geriatric medicine. After receiving her undergraduate education at James Madison University in Virginia, she attended medical school at the Ibero-American University in the Dominican Republic. This was followed by a family medicine residency at the University of Nebraska Medical Center with focused training on the urban underserved population and international health. After that, she went on to complete a geriatric medicine fellowship at the University of Wisconsin Hospital and Clinics with focused training on hospice and palliative medicine. Over the course of her career, Dr. Magsi has served as medical director and/or associate medical director for 3 other hospice organizations and a skilled nursing facility. She also has medical volunteer experience in both Mexico and Guatemala, and she speaks both Spanish and Urdu. Thanks for being with us today, Dr. Magsi.
Thanks, glad to be here.
I know you two have much to talk about, so let's jump right into the conversation. Trent, I'll leave it to you.
Thanks so much, Ryan. Dr. Magsi, it's so great for you to be a guest today. And by the way, welcome again to Hospice of the Piedmont and to North Carolina. Most recently having relocated from Florida, it's been wonderful to have you here, having joined our organization back in October. So it's been great to get to know you, and I look forward to the conversation that I know we're going to have today. As I think about sort of the topics that we're going to talk about today, it might be really interesting just to talk about your own sort of personal experience, right? And you grew up in Virginia, but you didn't grow up with Virginia parents, right? I mean,
right,
a little bit of a different experience for you. Might you talk a little bit about that?
Absolutely, sure. I'm happy to share a little bit about my background. It's really shaped and formed how I approach hospice and palliative care in my career as well. So I do, I'm happy to share that. So I was born in Maryland and on the East Coast to Pakistani immigrants. Both my parents were born in Pakistan and moved here before I was born, obviously. And grew up on the East Coast. I also spent some time in Europe as a child, lived in Holland for a little while, Denmark for a little while, came back to Virginia, did my high school undergrad, and then ended up in the Dominican Republic doing medical school. And that was a great experience, a very rich experience of being immersed in a third world country, learning Spanish, being immersed in a completely different culture. But I do think that my life experiences up until that point helped support that transition and made it a little bit easier for me, having lived abroad and being accustomed to working with people that were different from me. And so I did medical school, came back, ended up coming back to Nebraska, worked as a social worker briefly in a nursing home. And that also really helped sort of shape my journey into the world of geriatrics and experiencing a lot of end-of-life situations in the nursing home setting as well. So I went on to do a family medicine residency at University of Nebraska in Omaha with a special focus on the urban underserved population. Having done my training in the Dominican Republic, I was very comfortable interacting with patients who spoke Spanish primarily. And so that population, the majority of my primary care practice or my regular routine follow-up for patients were patients who were typically illegal immigrants. Most of them were from Mexican descent, but just a wide variety of folks. And so I had the hospital exposure. I also had that primary care clinic experience. And then I moved on to a geriatrics fellowship because life had sort of moved me in that direction. And so went to Wisconsin there and really, truly just loved the hospice and palliative care component in geriatrics and ended up doing further training in that. And since then, life just has taken me where I needed to be. I've worked in Wisconsin, Illinois, Florida, and here, and each time it's been great because even each state has its own sort of culture to it. So it's been very rewarding.
Sure. Well, I appreciate your willingness to share some of that. So as you think about your work in the urban underserved and, throughout the last 3 installments of this series, we've had discussions related to really broad topics, health disparities and health equity and health equality. And we've learned sort of the nuances of each of those. But as you think about those really broad topics, how do you think that your work with the urban underserved has really shaped the way you practice medicine? What understanding has it given you?
I think the biggest thing is knowing that people really appreciate the little things, right? Oftentimes, all too often rather, I think folks who are underserved, they're used to people sort of talking over them or around them or not giving them information. There's always this sort of underlying suspicion that maybe they're not getting all the options of treatment because of their socioeconomic status. And, I think when you do provide any level of help or care for them, there's such a deep appreciation for that. I think that's one of the biggest things. And just knowing that information truly is power. So whether or not someone is able to get a certain type of treatment or test or not, giving them the options so that they understand what those are, helps them to understand why a provider may say that, no, this is what you need to do. You don't just tell them this is it, because if you do that, then there's always this level of mistrust of the healthcare system.
So you see that sort of as, I'm sure, like any type of relationship, it begins to evolve. And I think what I heard you say is that at the outset, initially, there may be an element of severe mistrust or lack of trust, perhaps not mistrust, just lack of trust. For building that rapport and that relationship, for all the things that have, because of all the things that have sort of formed those opinions in those populations or among those groups, right?
Correct.
And so what you're really talking about, and I think you said it, is sort of beginning to gain their trust. And you gain that by helping them understand, I'm guessing, because I think most people, in my experience, when they begin to realize that you're being of service to them, they espouse a sense of gratefulness, right? And a willingness to accept that information that you may be trying to impart to them as a physician in this case, right?
Yeah, that's absolutely correct. I think too often when we go in and have preconceived ideas of what somebody should or should not be receiving and it may be a very medical decision, but if we don't take into account what they may have experienced and what may have led them to this point, it's very hard to steer the conversation forward and really develop a connection and an understanding and a trust so that you can actually give them a treatment plan and walk that course with them. Otherwise, you're constantly butting up against them, and it's just not as effective.
Yeah, I think, if I think back to some of the previous guests that we've had, it's the notion of making sure that we're giving everyone the right tools for them in a way that the tools are accessible to them, as opposed to just deciding that everyone gets the same tool, right?
Correct.
Yeah, I mean, that's exactly what I think you're describing. So as you look back on that underserved population, and you look sort of more prospectively now across your career as a practicing hospice and palliative medicine physician, what are some trends that you see as sort of this shared experience among all of these populations?
Yeah, it's a good question. I think it really boils down to two or three things, right? I really think everybody, when you're talking about hospice palliative care patient population, right, regardless of what their background is, there's really three things it boils down to. One, everybody has a survival instinct, right? So as soon as you tell somebody that they have a limited life expectancy, whether it's an acute illness or a chronic illness, that survival instinct kicks in. And once it kicks in, people will respond very differently to that. Typically, they will have a grief response. And so either they'll be angry, or they'll be depressed, or they'll be in denial. They may start bargaining, or they may be in full acceptance. You just don't know where they'll be at that point. So that's one key thing. I think everybody's survival instinct sort of kicks in when you tell them they have a limited life expectancy. Secondly, it's not just about the patient, right? It's about their family. It's about their support system. And so when this type of news is delivered, family really just wants to help, right? Now you've got every family member's response to it. So they had their own grief response, and then you have your patient, and they all, their grief response is directed towards helping the patient in whatever way they can. And then this can come across in very different ways, how they express that. And I'll talk a little bit more about that in a moment. And then I think the third thing is that the third trend I see is that people are so incredibly grateful for any help they can receive, that they do receive. And so, when you introduce a hospice or palliative care trained professional into the mix, they are trained to address the patient's needs as well as the family's needs. And they're looking at the biological, the psychological, and the social issues around it. And that's what, that's what my job is. That's what any hospice and palliative care provider or clinician's job is as well. So it's easy to address those things if you are aware that that's the response you're going to get.
What's so interesting, and as I'm listening to you talk about that, the notion of a survival instinct, of people having a desire to help, talking about the family, and then people are grateful for the information they receive. Those really aren't just isolated to underserved or disparate populations. Those are sort of normal. I'm thinking in my mind as I'm hearing you talk, and I'm thinking these are sort of normal traits, right? So, this is what everybody experiences. These are common sort of experiences that we all have, that we can all relate to, regardless of our ethnicity or socioeconomic status. It's, again, I think, going back to the way we receive information, the way we build trust, the way we create a relationship. Is that fair? I mean, absolutely.
And I think, I think the key thing with palliative care is understanding that, like you said, all people respond this way across whatever disparity we may be looking at every population, everybody in the population responds that way. What we need to do as professionals involved in the care of these people is to understand that although everybody goes through these things, each and every one of them will express it very differently. So if you take the time to listen and hear how they express what their needs are, where are the points where you can intervene and help palliate, help make things easier for them, then your approach will be different as well.
That makes total sense because, in our organization, as you know, we talk a lot about needs, wants, and priorities. What are your needs? What are the things that you want? And how important are each of those to you, right? And that's really what you're talking about. And I think one step further from that, for us as an organization, for you as a practicing physician, but for us as an organization, is taking the time to understand the things that these individuals, these populations, these families, these people need, versus just deciding that we already know what they need.
Right.
We don't really know what they need until they've had an opportunity to tell us what their needs are, what their wants are, and then how important each of those sort of things that they put into those buckets actually are to them, right?
Absolutely. And that's where, right. And that's where listening becomes so important, right?
Yeah.
To be able to go into a person's life and just hear them and understand what their path has been, what their journey has been, so that you can then meet them where they're at and not impose your own agenda on them. If you meet them where they're at and you work with them from that standpoint, you're definitely going to gain so much more ground in helping them, whether or not they succumb to your agenda, right? So no matter, if you know, for example, that CPR would be a terrible thing in this one particular person because of their specific case, but they want it no matter what, because their survival instinct is kicked in, right? And they don't want to compromise that. You have to meet them where they're at, and you work with them based on what their values are. And I think the beauty of a hospice organization, ours in particular, and across all hospices truly, is that once and if we're able to identify what it is that a patient needs, we have the resources to meet them, right? So if they have a spiritual need, we have chaplaincy support. If they have a social reason for wanting to choose something which may in the end actually be very harmful for them, we can help support them from the social work aspect. And of course, for symptom management, we have nurses and doctors to do all of that as well.
Yeah. I mean, it really is sort of a commentary on sort of taking the time to explore thoughtfully what people need and giving them a voice. I mean, one of the things that strikes me a little bit is that as an organization, many people see us as the prudent experts, right, in any number of disease processes, and but we know that the patient and the family are sort of they're telling us where they want to go. So in a sense, if you think about it for just a second, they have a roadmap. They know where they want to go.
Right.
But we have kind of this GPS that's, I know the one in my car, if I miss a turn, it very kindly tells me, hey, you can still get there, but we're going to take another route, right? And so we're sort of being their GPS, but they're telling us the direction that they want to go based on the map that they have, right?
It's exactly right. And again, I think we're so fortunate in the hospice setting to have the resources to meet them when they take a left turn, when they take a right turn. They may start off and in just one arena having specific needs, not even knowing that they're going to have so many other needs down the road, which again, most people have very similar end of life experiences as far as, we're all going to die one day, and having the support services available to you when you're in a hospice program is it's so beneficial. So I absolutely agree with that. Hospice is sort of your GPS system because they can tap into whatever resource it is that you need.
Right. And we try to take, and I think we're learning, these conversations that we're having are helping our organization learn how to navigate these in different populations of people much more effectively, and much more confidently, right? I think that's part of our goal too, is as we bring these conversations to the community and to people who are listening to this, it's as much about learning for ourselves as a learning organization, right? How we navigate this best for the populations that we serve and the communities that we work in. So, one of the things that I think about a lot is how sometimes we hold space, right? Many times I think people find a need to fill a room or a conversation with words. And sometimes, what's been your experience in that? Is that necessary?
Right. No, oftentimes, in order to, again, get to meet a person where they're at, you really have to know them, right? You need to, two people with the same diagnosis. They may not have the same treatment plan that would be beneficial to them. So you really need to hear them beforehand. And I think, that's something that can be very difficult, to just sit quietly and not fill the silence in with words, just because when you ask a difficult question, a patient doesn't want to respond right away. I can give you an example myself. I've been doing this for a very long time. And a few years back, I went to a conference where, you do small group simulations, and I've been doing this almost 20 years now. And at that point, it was over 15 years, and sat down with a mock patient and was explaining what hospice care is. And we had a mentor, and the mentor just stood behind me and kind of did one of those hand flapping things. Basically I was talking too much, right? I had a mock patient who didn't want to give me any information. And so I was giving them too much information. And it's something that no matter where you are in your career, how experienced you are, it's something to always bring back to light, that it's super, super important to listen, because if not, you're not going to be able to meet people where they're at. You're not going to be able to help them because you didn't take the time.
Right. What's so interesting, and I think this has been a sort of a common thread that I've learned, having had the privilege of meeting some really wonderful people through all of these discussions that I've been privileged to have over the last several months, is that we talk a lot about individuals and populations that are perhaps disparate, that struggle with access and equality and equity. But what I think I've heard through all of these conversations, and this one included, is that we're really experiencing life the same. It's just the lens through which we experience it is maybe a different color, is perhaps wider or more narrow than others. But I think what we're talking about are sort of, common human experiences.
Right. Yeah, that's exactly right. I think we all have a slightly different lens, and yet we all try to apply sort of a cookbook medicine approach to everybody that we meet.
Like the checkbox manifesto, right?
Exactly. And that it doesn't always work, and that creates frustration on patients and families' parts, also on staff, hospice staff's part, right? Because it's difficult when you have the tools and the resources to make somebody's pain better, but a patient or a family refuses that, right? But you need to understand how they're looking at the illness, how they're looking at the pain, what lens are they looking through? You can't look through your own lens. The whole point in providing good hospice end-of-life care is to switch the focus, listen and look through their lens, and then tailor a treatment plan to that person, to that individual. Because if you don't, and I think this is where, where health disparity becomes more magnified, is if we don't take the time to understand what lens they're looking at the world from, and we impose our own view of how something ought to be managed, that's when you have a harder end-of-life experience.
Sure. It's that notion that, my neighbor's life is not my life. It is my neighbor's life, right? And I like my neighbors just fine, in case they're listening to this. I like them a lot. But their life is different than mine. And I can't apply the same considerations to their, to their existence as I would my own, because they're different.
And in truth, I mean, you say your neighbor, but it could be your brother. You may have grown up in the same circumstance, and yet the way you choose to see the world, or the lens that you see the world through, is very different. So the approach to treatment to you would be very different. And again, those subtleties are only identified through conversation and listening, right?
Yeah.
You have to, this is the premise of it.
And I think the things that you're talking about now, that we've just spent a little bit of time talking about, are really sort of the foundations of health equity. Again, it's sort of making sure that everybody has the tool that is most appropriate for them, not the tool that we believe is best for them. Now, we have many tools, right? But not all of them are appropriate for everybody. And some patients and families will use them very differently than others, or some will not use them at all, or even to their fullest extent, right?
Correct.
But that's not a failure on our part. That's actually our sort of taking inventory and taking time to explore what they need. A lot of times, we say this a lot, that hospice care with our organization really is about life on your terms. I mean, and that's really what we're talking about. We're talking about living life on your terms.
Exactly. Right.
Spending time to understand that. So, you've just been with us for just about 6 months. And you've been sort of with us as we began these conversations over the last several months. Are you beginning to see that these are having an impact on how we go about engaging with patients and families? Has it improved our ability to engage with patients and families of every group, right? Regardless of their any disparity or their access to health services? I mean, have you seen that? Have you seen us begin to adopt some of these things?
Yeah, I do think I do see changes, certainly in our organization, and really in society as a whole, because it's so at the forefront of everything, right? The past year, having COVID barrel through all of our communities has really put such a spotlight on end-of-life care, and the difficulties of being able to access your loved ones. And I don't mean to skirt your question, because truly I think it is a disparity of sorts when you're unable to meet to see your loved ones as they're dying and whatnot. And so I think it's very similar in the hospice community as it is in the palliative care community. What we're seeing, how we can best address these things. So we're listening more. There are more people working on creating better tools to meet the needs of people who are at a lack.
Yeah, what I hear you saying, I think, is that our healthcare system has found opportunity to
Correct.
address these issues because we've now seen them highlighted in ways that perhaps we've never really paid attention to them before. And again, I think I don't think I can underscore this enough, that really what we've talked about are really sort of common human experiences that aren't about color or socioeconomic group or urban versus rural. They all have different experiences because their lenses are all different. And so it's incumbent upon us thinking about the checklist manifesto is to sort of think about, let us not apply the same sort of programmatic approach to every single person. Let that live in the background. Let it not be at the foreground of everything that we do. Is
Right.
I think
I
that's
think
what I heard you say.
that's absolutely right. I think COVID has required, has put an urgency on how we innovate and we change directions on how we provide care. And so it's the same sort of thing that I see trickling down to all other organizations, including our hospice organization. There is that the acuity of what we've all experienced is trickling down so that we're seeing what the chronic areas of disparity need to be addressed as well. And so, so I think we're seeing that in our inpatient units, we're seeing that in our home patients in the community, that we don't have to have an acute trigger to address the needs as they show up. So I think everybody's a lot more aware of those types of issues now.
Yeah, because I think everybody's going back to where we started. Everybody has had a survival instinct.
Right.
I think everybody has had a desire to help, and everybody has been grateful for the information. And I'll sort of add to that, and the service that they've been able to receive. Right.
Absolutely.
Yeah. So, one of the things we haven't talked about that I think would be worthwhile for us to talk about, particularly among urban or rural underserved or even disparate populations, is, I've shared already some of my own experiences in recent episodes with sort of beginning to understand the influencers in people's lives. And for many of us who live very perhaps differently, or again, to use a term, to view the world through a very different lens, an influencer for me is my physician. But that may not be the same case for other populations of people or other individuals. It may be influencers that are external to the professional world, or people who are directly involved, in this case, in their healthcare, right?
Correct.
Can you talk a little bit about that?
Yeah, I think again, the palliative hospice approach to patient care lends itself very well to understanding who those influencers are, right? So if you meet someone for the first time and you're spending that time listening and hearing, then whatever area that needs to be addressed is identified, whether it's biological, psychological, or social, biopsychosocial, wherever it might be. You can tune into that as the patient is talking to you and telling you about their story and how they, the lens they're looking through it, how they view things. You pick up on, well, this person's faith is really important to them. this person's experience with their spouse who died with morphine is really important to them. This person's experience of losing a child 20 years ago, the trauma of it is really important to them, right? So there are very different situations that will come in and influence a person's lens, right? And so our goal is not to change their lens, but to connect them with the resources to help them work through any barriers to good care. And oftentimes that, once you identify what barrier needs to be addressed, and who the influencers are, then you can pull them in, right? So if you have somebody whose faith is super important to them, they may have a minister who can connect with them much better than a physician, or we can pull our chaplain in there, and on it goes. So you don't have to, just because we take the time to listen and get to know somebody doesn't mean you have to be the one to provide the patient with the tools. Your job is to connect them with the resources, give them the tools to help move them forward.
Yeah, it's so interesting you say that. It sort of reminded me of a conversation that I had with a dear friend of mine just in the last few weeks. And her mother was very ill, and we were having a hospice conversation, right? Her daughter was asking me about hospice services for her mom. And her mother is very religious. And her mother had just come out of the hospital from a pretty protracted hospitalization. And but her mother is devoutly Catholic, and made the decision that she did not want to go back to the hospital. That was her decision. But before she could make that decision fully, she had to talk to the priest.
Absolutely.
And the rationale, it was so interesting to me, because the rationale behind that was her mother is well into her 80s. The rationale behind that was because her mother needed to make sure that her making that decision not to go back to the hospital was not the same as suicide.
Right.
And so her mother sort of knew what she wanted, but she was striking this really delicate balance between my faith and my faith traditions and beliefs, and what I think I really want for my healthcare, because I don't want to go through all of that again. I think that's a real world example, I think, of exactly what you just described.
Yeah, that's so incredibly common, and really powerful. It powerfully illustrates, just that point. And in truth, a lot of times people want and need permission to move forward with the decisions that are really theirs. They've made the decision, but in order to get from point A to point B, they have to have someone's support, validation, permission in order to do that. And that's where the influencers become so incredibly important.
Yeah, I mean, that was a really fascinating. There are two of those in the most recent few months that I've had that were just really sort of influential to me, to realize that, there are many factors at play in someone's life that really shape the decisions that they make. And I know that sort of academically, and in my heart, I know that, right? But to actually hear that play out is really, pretty powerful, actually.
Right.
So one of the things, Dr. Magsi, that I think about is, we've talked about influencers, we've talked about sort of this survival instinct and the gratefulness we all have for help. And we've talked about sort of how all of this is sort of, emblematic of the human condition, right? So we all experience this regardless of, what our zip code is, or, what our ethnicities are. But then we've talked about how we how we interface with them as a care team, right? And then And then it sounds like what we're also talking about, though, again, is giving people the right set of tools. I know we've said that a lot, but I think we can't really not say it enough, is giving them the right set of tools that they have to be able to navigate this. I think it's fair to say, and I'm interested in your thoughts on this, that people, and you alluded to this when we first got started talking, when people get, the first sense, maybe, that they have a life-limiting illness, or maybe they've known it for a long time and now their disease has progressed to a different phase. Sort of regardless of where they are in that trajectory, there is always an element of sort of life review and how did I find myself here, right? So there's still people, I suspect it's fair to say that people go through the many different stages that we've talked about multiple times.
Oh,
Anger,
definitely.
denial, bargaining, all of those things. They go through that, I suspect, multiple times during the cycle of their disease process. Is that fair?
Yes, that's absolutely true. Day to day, minute to minute, it can change, and that can be very difficult for patients themselves to navigate, as well as their families and loved ones. And that's when the tools become so important. That whatever tools that we can continue to put in their tool belt, they can pull those out. And whether that's connecting them with inside resources, outside resources, having someone just to call, right? Having a nurse team member to reach out to when all of a sudden someone who's been fine is crying unstoppably, right? It puts a stress on the whole family system.
What you just described, having someone to talk to, when I think about the spiritual support and the psychosocial support, there really isn't always a pill for that, right?
Correct.
And sometimes words are not what's needed, but listening and hearing actually, and understanding actually is.
Absolutely. Absolutely. And I think that's where, the team approach that hospice takes to each individual patient that comes onto service becomes really important, right? We don't just send 3 different types of social workers, 5 different nurses, 3 other chaplains. We try to have the same unit of people who can really get to know the patient and then meet them where they're at, and then work with them to build those tools and to be that GPS system for them, as you mentioned earlier, right? I think it's a unique program that exists, and unfortunately still a lot of people don't even know about, right? And so when we are able to be involved, there's so many research studies that show it helps improve patient symptom management and improves caregiver stress. But it's that team approach, I think, that gets us that level of trust and comfort for the patient and family.
Sure. And when we talk about access, many times there are people have perceived barriers to healthcare services. It costs too much. It's completely out of their reach. And in reality, as a community-supported nonprofit hospice organization, Hospice of the Piedmont and our affiliate organization, Hospice of Randolph, really exist to provide those services regardless of socioeconomic status, regardless of financial circumstance. It really is sort of, we have an investment we have a distinct investment in taking the time to understand the lens through which you see the world. Because that's the only way that we can truly be of tremendous service to the communities that have supported us for the last 41 years.
Absolutely.
So, Dr. Magsi, as we sort of wrap this conversation up, I want to ask you, as I've asked every guest, if we've talked about a lot of things today in a brief period of time, but is there 1 or 2 things that we didn't talk about that you're like, I really want to make sure that I get this across? And what might that be? Or maybe it's a story that you think of that sort of really shaped your practice or your experience, any of that.
Yeah. I think a couple points that I think I would really want to empower people with, is one, knowing we're all going to have some point in our lives where we have a loved one who will go through an end of life sort of experience. And the best way you can help them really is to be open, to listen, to provide that support. Be curious, right? Don't assume you know anything. You may have known somebody for 50 years, but still listen, ask them the question, be curious, stay open, and don't have an agenda, and you'll be able to navigate through any situation. We're all going to reach this point at some point. All of us will die, but no two people will have the same experience. And so, we want to meet everybody where they're at. And so in order to do that, those are the second suggestions, the recommendations I would have.
Those are powerful. I appreciate that. I thank you very much for the opportunity to have had this really wonderful conversation with you. I'm going to turn it back over to Ryan.
Thank you so much.
And let me echo that. Thank you both for allowing us to sit in on this conversation. We appreciate you, Dr. Magsi, for taking the time to share with us your background and how it has shaped not only why you became a palliative care physician, but also your approach to providing that care. Thank you for unpacking your knowledge and your many years of cross-cultural experience with underserved urban communities, and showing us how that population is similar in many ways to the populations and families we serve at end of life. There sounded like there is a universality to valuing knowledge and appreciating an empathetic listening ear when experiencing a medical crisis or grief at any stage of life, really. So I'm grateful that it sounds like you and your team at Hospice of the Piedmont really make those things a priority as you build trust and meet a patient and family where they are, bearing in mind all of the disparities they may or may not experience, and offering them the care they need on the terms they choose at end of life. So we just appreciate you and you taking the time to unpack all of this and so much more for us.
Thank you so much.
I'd also like to thank all of our listeners who have joined us for our e-series discussion on health disparities. This series, as well as all of our previous installments, are available on podcast for download at both our website under resources and on SoundCloud, Google, and Apple Podcasts. Lastly, be sure to tune in to our next installment of the e-series, where we will explore the intersection of faith, spirituality, and health, and how this relationship tends to affect our values, decision-making, and overall well-being. We hope you will join us. Until then, I'm Ryan Biagini, and this has been the e-series.